Good morning. Thanks, Hugo, for having me out here. So I will give you an overview of what the ASSLD guidelines are for treatment of hepatitis C, and then we'll have time for discussion because it is not possible to go in great depth of all the studies that support these recommendations. So I will address the various genotypes and the various populations among the genotypes by way of being treatment naive or prior non-responders. So let us first look at genotype 1 patients. These are treatment naive patients and also prior relapsers. So for those who are interferon eligible, the recommendation is sofosbuvir, pegylated interferon, and ribavirin for 12 weeks based on the neutrino study, and these drugs are, of course, available. For not interferon eligible, based on COSMOS study, which, as we discussed several times, is a small cohort or two cohorts of 160 patients plus, and they recommend sofosbuvir and cimeprevir with or without ribavirin for 12 weeks. Now, you could then go on to alternative regimens, and this would be of cimeprevir, a protease inhibitor, along with pegylated interferon and ribavirin for 12 weeks, followed by a tail of peg and ribavirin for another 12 weeks. For not interferon eligible, you could consider sofosbuvir and ribavirin for 24 weeks, and these are alternate strategies. Now, you have to understand that there is a little bit of a difference between 1A and 1B with cimeprevir, in that good number of patients with 1A have baseline QADK polymorphism, yet they are candidates for cimeprevir along with pegylated interferon and ribavirin. If you look at sofosbuvir and ribavirin for 24 weeks, you'll see a footnote that this may be less effective than sofosbuvir and cimeprevir, particularly for those with cirrhosis. Now, what is challenging from this perspective and quite contentious is that the guidance document says that talaprevir and boceprevir, along with pegylated interferon and ribavirin, are not recommended. So this is, as I pointed out, contentious because in fair number of countries and other parts of the world, these are the drugs that are standard of care now, and in fact, these became approved only recently. So to say it's not recommended presents quite a bit of a barrier for treating physicians as well as patients, particularly where patients are demanding what is said in the guideline when they do not have access to these drugs. One thing also has to be kept in mind is that cimeprevir is not to be used in decompensated cirrhosis. There is quite clearly stated in the package insert that child class B and C patients are not to have cimeprevir because there are no PK studies in cirrhotics, advanced cirrhotics, and the area under the curve could be quite enhanced. Yet, given the availability of this in the US, people are using it with some consequences. Now, the basis for these recommendations are these multiple studies, which I will not go into. I'll be glad to talk about them during the discussion period. For cimeprevir-based regimen, it's Quest 1 and 2. I've talked about COSMOS study and the variety of other studies that have been done with sofosbuvir and ribavirin plus or minus pegylated interferon. Now, what about prior non-responders, genotype 1? The recommended therapy, again based on the COSMOS study, is sofosbuvir and cimeprevir plus or minus ribavirin for 12 weeks. These are patients who had prior non-response to interferon and ribavirin. The alternate regimens are sofosbuvir for 12 weeks, along with pegylated interferon and ribavirin, along with a tail of 12 weeks of peg and ribavirin, sofosbuvir and ribavirin for 24 weeks, and then cimeprevir for 12 weeks along with pegylated interferon and ribavirin, and 36 weeks of pegylated interferon and ribavirin. Again, not recommended are boceprevir or talaprevir along with peg and ribavirin monotherapy, and also in decompensated cirrhosis, you'd have to be careful with cimeprevir. And the basis for these recommendations come from these studies. For cimeprevir for non-responders is the phase 2 study called the ASPIRE study, and you have other studies with boceprevir and talaprevir, respond, provide, realize, etc. Now, what about genotype 2? If you were to look at recommendations for any of the genotypes, the only one that is kind of crisp is genotype 2. For treatment-naive, prior relapsers, and non-responders, if you look at first treatment-naive and retreatment of PEG and ribavirin relapsers, it's sofosbuvir and ribavirin for 12 weeks. There's no alternative therapy, sort of very interesting. It says not recommended pegylated interferon and ribavirin. So what do you do in a country where sofosbuvir is not available? Of course, pegylated interferon and ribavirin works very well for 24 weeks, so it certainly can be considered in genotype 2 patients. And if you were to look at prior non-responders, again, it's sofosbuvir and ribavirin for 12 weeks. If a patient has cirrhosis, there might be an advantage to extending treatment to 16 weeks. An alternative therapy, it's sort of interesting that it's presented as an alternative therapy of sofosbuvir, PEG, interferon, and ribavirin for 12 weeks. But the limited data does suggest that it works quite well. And when it comes to physicians treating these patients, that actually might be a preferred regimen, particularly when it comes to genotype 3, which I'll talk about. So genotype 3, if you look at initial treatment for patients with genotype 3, it's sofosbuvir and ribavirin for 24 weeks. An alternative therapy eligible for interferon therapy would be sofosbuvir, PEG, and ribavirin for 12 weeks. And as I pointed out, for genotype 3, one might prefer this regimen over 24 weeks of sof and ribavirin. We can have a discussion about it. Again, not recommended is pegylated interferon ribavirin, although in parts of the world where sofosbuvir is not available, pegylated interferon ribavirin is still a very viable option for genotype 3, although the challenge is that they tend to relapse more than genotype 2 patients, yet they have pretty good SVR. Now, for non-responders, it's sofosbuvir and ribavirin for 24 weeks. An alternative therapy is sof, PEG, and ribavirin for 12 weeks. Now, it's sort of interesting that, although cimeprevir is not recommended, there are some people using it. It has to be absolutely made clear that cimeprevir is not to be used in genotype 3 patients. Now, the basis for the recommendation comes from various studies that I've listed here. For sofosbuvir and ribavirin, you have fusion, fission, positron, valence. And for sof, ribavirin, PEG interferon, you have the Lone Star 2 data, the proton study, and for other combinations, you also have the electron study. Now, for genotype 4, which may be infrequently seen here, if you look at these patients, you can consider or use sofosbuvir, pegylated interferon, and ribavirin for 12 weeks. This is based on the neutrino study. There were 28 patients of genotype 4 in the neutrino study, and 27 of 28 achieved sustained virologic response. Alternative therapy eligible for interferon therapy would be cimeprevir. It does have activity against genotype 4 for 12 weeks along with PEG, interferon, and ribavirin for 24 weeks in treatment naive, or for 48 weeks as well in treatment naive patients. Now, there is this alternative therapy for interferon ineligible and prior non-responders of soft pegylated interferon and ribavirin that can be used. I apologize, it should not be pegylated interferon, it should be soft and ribavirin for 24 weeks. There is no pegylated interferon, soft and ribavirin for 24 weeks. That's what I meant to say there. It can be used, but done in a little cohort of patients, and the basis for that is this study from Rouen, where they treated some North American patients with sofosbuvir and ribavirin for 24 weeks and had good SVR. Yeah, the neutrino study, which I talked about with sofosbuvir, ribavirin, and pegylated interferon for 12 weeks with a good responses. And there are some preliminary data with cimeprevir. There's one study, the phase 3 study that's going on is called, is an ongoing phase 3 study. There's another one as well called the Restore study. It's likely that you'll see more data come out as we move along. So at that stage, I'll stop and then go on to the other guidelines, and then we'll have a discussion on what might be the right thing to do. Thanks.